So it is my pleasure to introduce Reverend Joel Coppieters. He's the Reverend of the Côte-des-Neiges Presbyterian Church, which is very close to the Jewish General and is situated in between Hôpital, two hospitals, Hôpital Saint-Justine and the Jewish General Hospital. And the Presbyterian Church of Côte-des-Neiges is a very old church. I think it may be one of the oldest, maybe
Yeah,
the oldest in Côte-des-Neiges.
we're the oldest in Côte-des-Neiges.
Côte-des-Neiges. It's kind of a historical site. There's a fascinating steel roof that was recently replaced, I guess. Huh?
Yeah,
And Joel Coppieters leads a very ethnically diverse congregation. And he's also somebody who has quite a bit of insight psychologically, Reverend Coppieters. He's been a collaborator of ours for several years. And he's helped us in many ways to understand quite a few aspects of community psychiatry and mental health. So we're very grateful to have him talk today about some of his experiences, having working with his congregation, members of his congregation, from the pastoral aspect. So thank you, Reverend.
thanks, Eric. Thanks for the intro. So
Mhm.
just a couple warnings as we go. I realized that to some of you trained clinicians and medical professionals, there's a chunk of what I'm going to share that's going to feel a little bit anecdotal, but that's because that comes from the experience in the field. Two things, though. The process of training for clergy these days includes more and more basic training with psychiatric issues. So along the process, in my case, 2 degrees, bachelor's and master's of divinity, beginning of a doctoral degree, we get more and more exposure to some of the basic psychiatric issues in terms of general preparation. And then in my case, before ministry, I was almost 3 decades in business. And so that included a lot of work in human resources. And as part of the human resources training as well, there's a number of psychiatric issues that we're just made aware of in the process. The other comment I was going to make is that I'm not going to focus exclusively on the issue of first episode psychosis. Going to be a slightly wider discussion of mental health, but certainly we'll keep the first episode psychosis sort of front and center in our minds as we go forward. I want to take you back to the scary days of your high school math class. I don't know if you remember doing Venn diagrams in math class. So do a little exercise here in Venn diagrams. We've got a bunch of pets in front of us. We've got dogs and cats. And if we do the Venn diagram with a circle includes the dogs and cats on the other side. So we've got two separate circles. So there's no intersection. But sometimes if we've got different animals, we might have an intersection. So for example, I've got dogs on the left and I've got my pets on the right. And so if I make a circle that includes all the dogs and another circle that includes all my pets, there's an overlap in the middle. There's our little dog there that's both a dog and a pet. So there's a little overlap. So I think about the work of caring for individuals who have mental health issues to deal with. And some of the work is done by the clinic, some of the work is done by the church, and some of the work is done by the wider community. But we really don't think of it as three separate circles. We really think that the three circles overlap. And there's places where the church and the clinic work together. There's places where the community and the church work together. And there's a place in the center where there's a room for all three. And so that's how I'm trying to get my head around the pastoral element that the church and the church context brings to mental health care. So I want to do three things with you this morning. I want to take a look at the things that the church does well, or at least that the church should do well. So we'll spend a little bit of time talking about just the pastoral element alone in the church context. Then I want to look at navigating the overlap, those areas where both the clergy and the clinician need to work together to help the patient. That third piece of the community, we've had a couple of workshops that have spoken about involvement and connection in the community. And so I'm not going to say much about the wider community. I'm going to let that happen in some of the other workshops we'll have. But I do want to cover a third piece before we end. And I've sort of called it a collection of provisos, cautions, and recommendations as we end. So let's take a look first at some of the things that the church should do well in caring for mental health. The first one is we feel that the church should do well to be a safe place of welcome and refuge for struggling people. For most of us in most of our lives, most of the places where we are, we have to be at our best behavior. We have to be at our best. We can't show any sign of weakness. And particularly, there's still a lot of stigma around mental health issues. If I'm at work in a highly demanding professional environment, if my colleague in the cubicle next door realizes that I'm struggling with a depression or I'm struggling with a mental health crisis, that could have pretty hard impacts on my career and my advancement in the company. And so most of the places where we are during the day and during the course of the week, we have to be at our best. We have to be at our best behavior. We can't show a sign of weakness. If there's issues of mental health, we have to try and keep those sort of hidden. But the church is a place that's a little different. It's the one place we go where it's okay to struggle. It's okay to put your hand up and say, I need a little help. I need somebody to pray for me. I need a little help with my family, with my kids. And so in a sense, that's the place where it's safe for somebody to step forward and ask for help. And we're hoping that in cases where there's a mental health issue, that we're a safe place where somebody can raise their hands and say help. Um, the second thing that the church does well, I think, is that we're called to deal with issues that are more spiritual than clinical. Let me give you an example. My grandparents immigrated from Belgium in 1953, and with my dad and my aunt. And the process was pretty hard. My grandfather had a hard time during the war, and he came out of that pretty close to the bottle, did a lot of drinking. And my grandparents had been here for about 3 months, almost 4 months. And my grandmother got up one morning. There was a note on the table from my grandfather, and the note said, "I don't like it here. I'm going home. Good luck." And he left his wife and 2 kids here without any money, without a job, and disappeared. That was the sort of the defining moment for my grandmother, and she never got past that. And for the rest of her life here in Canada, even the happy moments, we'd share an ice cream together during the summer and say, isn't it great, Grandma? There's a nice sunny day where, a nice ice cream cone. And well, who else liked ice cream? Your grandfather liked ice cream, and he abandoned us and he walked out on. And every event for the rest of her life was sort of brought back to that moment of anger and frustration. And later in life, as she struggled with what she felt was a bit of depression, and she went to a number of psychiatrists and counselors, who was always looking for some magic medication to sort of get her past that anger and that frustration. From my perspective, of course, as a clergy, part of what she was dealing with was the need to deal with forgiveness and to get past that incident. So there are incidents in people's lives where there's mental struggles, emotional struggles, but sometimes there's a spiritual component that we need to look at before we go to a prescription or to a clinic. The third thing that church does well, because we are welcoming to people who struggle, I think that we're called to be part of the early diagnosing on the front lines and then referring to professionals when that's needed. So I've got a lady in the congregation from Trinidad, and about 2 years ago, we realized that about 6 or 7 Sundays in a row, she was wearing exactly the same clothes. There was a body odor issue. There was some cleanliness issue. And she has no other family here. And so as we worked with her, we realized that there was some early onset dementia. We realized that in terms of her own personal care and hygiene, there were issues. And so often, particularly for people who come regularly to church Sunday by Sunday, as clergy and as those of us who are in the congregation surrounding them, some of the early warning behavior signs, particularly for people who live alone or isolated, we have an opportunity to sort of do an early diagnosis and say, okay, there's an issue here, to initiate a conversation and then to make the referral to professionals. Fourth thing we do well is offering surrogate family support for the isolated. So in the congregation, I've got about 15 to 20 international students. They're here alone. Families are back home somewhere in another country. We have a lot of new refugees. I've got 2 or 3 single moms who are here with a couple of young children with no husband, no family, no support. Particularly for Africans in Africa, it takes a whole village to raise a child, and so a new mom with a couple of young children, normally her mom and her mother-in-law and the whole village, but they're very isolated. And the same thing is true for shut-ins. So as individuals deal with mental health issues, and we've talked about this repeatedly uh, surrounding psychosis, for instance, that part of the healing process and part of the recovery process really requires a family of support around them. And so for individuals who are here isolated, the church often provides kind of a surrogate family. Number five, something that I get away with. I'm hoping some of my clergy colleagues do this. I do a lot of visiting. So that lady, for instance, who we realized after 6 or 7 weeks had been wearing the same clothing and had problems with hygiene, um, without an invitation, I just showed up at her house, knocked on the door, and said, "I'd like to, can we have a cup of tea?" We sat, we prayed together, and that gave me a chance to see in her home, to realize that it wasn't just her own care. I realized that the care for her house was lacking. I realized that, and so often as we do that early diagnosis, a clinician or a professional from the CIRS or from the CLSC, they're limited unless there's a real issue of immediate danger that requires almost calling 911. It's very difficult for somebody in the medical network to make that kind of home visit without an invitation. But as clergy, we have the opportunity to do that in a very soft way. Number six, we are a setting that provides appropriate social connections. I have an interesting lady in the congregation, and we'll call her Helen. And Helen has a couple of paranoia issues and borderline personality disorder. And as we work together, she's been followed by a clinician, and there's medication that she takes, but there's little social cues that she has a hard time picking up on. Um, Helen will have a conversation with you, and she'll approach you, and literally her face will be 3 inches away from your face, just very, very close. And in the community setting or in her family setting, there's a very harsh reaction to that, and so she's isolated herself from family. But in the church context, there's opportunity for other people who work with her to kind of gently give the social cue. You're a little too close, Helen. Let's sit a chair. Those kinds of things. Um, Number seven, we provide the helpful regular patterns in the ebb and flow of life. I've got about 30 or 40 retirees and about another 20 or 25 people in the congregation who are on permanent disability. They don't work Monday to Friday, 9 to 5. And the whole week sort of becomes a blur of 7 days just rolling one into another with nothing punctuated. And for many of them, the fact that there's that Sunday morning service at church at 11, that becomes part of the regular pattern. And as I see them on Sunday morning, and then we have conversations about how their medication is going, about how their appointments are during the week. But for them, that connection with that worship service becomes part of what gives regularity to day-to-day life. And that goes a step further then through the long-term seasons and changes of life. As life goes on, children are born, we get married, people die, there's divorces, we move into new homes, we move away from home. A lot of those moments can be pretty traumatic. There are moments of pretty significant adjustment, and the rites and rituals that connect them to the church make births and marriages and deaths and new homes and moving away. Those are moments that, instead of living alone in the trauma that they can bring, we celebrate them together. There's a prayer that we say when a new child is born. When we're married, there's a little ritual that we go through together. When somebody is lost to a death, we meet together, and there's prayers that we say, there's texts that we read. And it has a way of bringing a normalcy and a stability through moments of life that can bring great upheavals. Number nine, there's a grounding and a resourcing that happens through the disciplines of faith. And so the prayer in the morning, the meditation, the reading of the sacred texts, all of those elements of the faith, of the life of faith, of the disciplines of faith, help to bring some grounding and some stability. Number 10, we encourage people to seek help in moments of crisis. I noted when we started that a lot of places around us encourage us to hide the challenges that we face, or to hide the struggles that we have. But the church is a place where we say, look, I think you're can I help you? Can I go to the clinic with you? Is there something that I can help with? There's that encouragement, not just to put your hand up, but to seek out the help when you need it. Number 11, particularly for our seniors and for people who are living without a family connection, the church provides follow-up after the medical process. I've got, by my count, about 11 or 12 people in the congregation who are on a variety of forms of medication for mental health issues. And they check in with me, and I check in with them. There's 4 among them who really don't like to take their medication. And so on Sunday morning, when they come before the service, they sit in the sanctuary, I go, I say hello. And I don't do it every week because it would get onerous, but every 2 or 3 weeks, I'll actually take the initiative and say, so Bob, how's it going with your medication? Have you renewed your prescription? Are you okay? We've got a couple of people in the congregation as well who struggle financially and who are far from the clinic. And so for them, just having the couple dollars required to take a taxi or to take the bus for their next appointment or to renew their prescription can be difficult. And so it's quite frequent that I'll make sure somebody has a taxi or a lift, or somebody has the couple dollars they're missing for the copay on the renewal of their medication. And in number 12, we help to bridge the gap between the culture back home in the new Canadian context. We've spoken quite a bit about that struggle as we arrive as refugees and immigrants. There's a completely new context in Canada. It's very different than Trinidad or Cameroon or Korea, and we try and navigate that. And the church is a place where we meet other people from back home, but other people who are struggling with their new Canadian identity, and that is a helpful process. So I think those are 12 things I think that the church should do well, at least, and that we bring to the table in terms of helping through with the mental health process. Let me just look now at that area of overlap, the area where there's things that the church and the clinic need to do in collaboration, and some of the things that we need to do. Some of these are observations and recommendations on the side as well. I talk about the need to educate the clergy. We've had a couple of moments. We had an evening actually where Dr. Jarvis and part of the team came to a presbytery meeting for the Presbyterian Church, and it was a chance to talk to a lot of the clergy about some of the process of early psychosis in some of those mental health connections, and we need to do more of that. Part of that we do within the church, and part of that we really need the help of the medical network and community to help us better educate our clergy as frontline help. And then I talk about educating clinicians a little bit. It's been interesting. I've got a couple of friends who are doctors and who are in the clinical world who will regularly call me and say, I've got somebody I'm helping with, and they made a comment about a baptism, and I don't understand. What did he mean? And then so that kind of goes both ways. And then keeping the doors of collaboration open once we make those connections. And there's 2 of them here, I think 2 steps. Number 3 is the practical things, and number 4 is building the professional relationship. So let me give you a couple of examples under number 3. When we're in the process of training for clergy and for ministry, one of my mentors made an interesting suggestion. He said that in my office, I should have a referral list. And so I've got a 1-page sheet. If somebody comes in and they need to quickly draft up a will because somebody is in critical context, I've got the phone number of a notary that I can call. If there's a poison control issue at home, I know what the poison control phone number is. Now I know if there's an early psychosis in the congregation, I know who to call. I know what the process is. And one of the things I appreciate from the medical network is that I've been able to get phone numbers and contacts and connections. And so we need to build those open doors. And I'm hoping the other way as well, that there's a couple of my clinician friends, if ever they get in a context where they've got a hard question, or maybe need somebody to come and say a word of prayer, if that ever happens, that they've got my phone number as well. But number 4 goes a step beyond that. It's more than just having somebody's phone number and knowing who to ask questions to. There's a respect that's built both ways. I'll never forget. I was with a family, and there was a pretty advanced case of cancer. There was a pretty dramatic surgery that removed quite a bit of tissue. And after the surgery, as we were in the recovery in the room after, I was there with the family and the patient who'd been operated, and the surgeon came in just to double check. And the surgeon told the patient, "Well, it went well. We removed the whole mass. We think we got all the cancerous tissue. We think you'll be okay." And the patient's wife said, "Oh, thank God." And I'll never forget the surgeon said, "No, no, 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 no. God had nothing to do with this. Thank me. I did the surgery." Um, so there's these moments where that the collaboration, you need more than just having somebody's phone number and knowing who to call. There's a need to work through it with mutual respect a little bit. One of the tricky things about navigating the overlap is that we need to work at figuring out the confidentiality issues. I find often when I'm visiting a family who's in palliative care in the intensive care unit, between the medical staff and there's details that they'll give to family. And I'll arrive at 2 o'clock in the morning because I've been called for the last rites, or somebody just has a few hours left to live, and I've been called as clergy. We're still sort of working out the questions. How much do they tell me? If I'm there alone and the closest family is in Toronto, I'm the only one there, I'm not family. Are they allowed to tell me things as clergy? And then it gets even a step more complicated if it's not an end of life issue, if it's a young person struggling through psychosis or through a mental health crisis, and either family's not there or is not available or is struggling with the issue as I arrive as clergy. How much do I say and how much do I get included in the conversations? Um, and so that's an issue that's a little tricky to resolve sometimes that probably warrants some conversation. And finally, I call this making room for faith in the medical setting. One of the things I particularly appreciate about the Jewish General and St. Mary's that's nearby, often when I get called in end of life issues, the staff and the treating physicians are very kind in allowing time. There's a couple of other hospitals when the patient dies, there's immediately a nurse standing in the corner of the room looking at her watch, kind of hinting that, we need the bed and we need to clean out the room for somebody else who's coming in. And sometimes family needs to take that moment to pray after the death, to struggle with the faith issues. Um, there are some hospitals where it's a little easier for me to sneak in with the sacraments, with communion on a Sunday afternoon for a patient who's been there for a long time. And so those are issues from our end that we appreciate, particularly at the Jewish General, that there's an effort to make room for those issues of faith in the medical setting. And let me just quickly wrap up with three quick provisos, and then we'll go into questions and exchanges a little bit. Just three of these, really. One, just to let you know, and I think this is almost the same as in the medical setting, there's a dramatic critical shortage of clergy in Montreal across all denominations. In the Presbyterian setting, for example, in the Presbytery of Montreal, we've got 31 congregations and we've got 11 ministers taking care of 31 congregations. So it means that each one of us is responsible for 3 or 4 congregations, 3 or 4 parishes, and it's the same stretch in all denominations, I think. So as you work with clergy, remember that we're short staffed as well. We're stretched. And unfortunately, many of us, probably more so than the medical setting, a large number of us are past our prime in terms of age, and many of my colleagues are sort of products of a previous generation. I'm pushing 60 this year, and I am among the dramatically younger clergy in Montreal. Most of my colleagues are 10, 15, 20 years older than I am in some case. So bear that in mind as you work with the clergy, and bear in mind as we make the transition in technology and new medical technology, there's a struggle there. This you're probably aware of. Several faith groups are less welcoming of clinical and medical involvement in mental health. There's some faiths that have restrictions in terms of what they can do with general medical stuff, and there are many faith groups, unfortunately, who don't. I'm not sure how to express this tactfully, who don't recognize mental health issues as an issue. They believe that all of it is spiritual. And so that can be a struggle sometimes as we try and make connections between the clinic and the church context. And finally, the third change, just to flag you to, that's increasingly concerned for us, we call it the challenges of laïcité. And I work in this strange context just about daily. Um, we've been helping a mom from the Democratic Republic of Congo who arrived here alone, and she found out she was pregnant after she arrived and made a refugee claim. And she had quadruplets. You may have seen the news coverage. And so, as a church, we've stepped in to help her, and we bought cribs, and we've been providing diapers. We've been helping that process. And it's the doctor at Saint Justin who called me from the birthing center who said, "I got your name from a friend who said that you might be able to help." And so I went in to meet them, and then they walked me through the situation. But um, we have this strange, tense relationship. The doctor realizes is not religious, realizes I'm a pastor, realizes that there's a church and a faith connection for me, realizes that the lady from Congo herself has a faith background, but kind of the doctor kind of felt like he was crossing an inappropriate line because he called in somebody religious to help in a secular hospital with a, and so I walk that narrow line regularly. The local CLSC and several of the clinics call on us for emergency food baskets. They do that and they appreciate our help, but there's always this sort of tension a little bit. Um, they worry when I go and make a delivery of a food basket. Am I going to go show up with a Bible and pray with the family? Is that and they struggle with that. And so for us as people of faith, increasingly here in Quebec, as laïcité becomes the official tagline, there's even discussions about whether or not it will be permissible long term for us to pray in public, to pray on a street corner. And so every November 11th, when I lead the service at the cenotaph for Remembrance Day, and I work with the vets, many of them who are people of faith, and we're there in a public park. They have lost friends and fathers and grandfathers to the war. They want me to pray. They want me to read a text of scripture that's comforting to them. But there's a growing discomfort from the city administration that I'm in a public park at a public place and I'm going to offer a prayer and read a sacred religious text. And so those are all that laicite concern is increasingly something that we keep an eye on and that we struggle with as clergy.
Mm-hmm.
My only other comment is I wanted to tell you that it's really a privilege to work with you to care for people that are really precious to us. We realize that a lot of the people that we work with and a lot of people that we care for become very dear and very close and precious to you. And for us, they become members of our extended family. And I get calls at 2 o'clock in the morning for palliative care for somebody who's about to pass away. I get when somebody's daughter runs away from home and disappears. I'm often the first call before they even call the police. And we really appreciate the fact that particularly clinicians and professionals in mental health, often like us, you go far and above beyond the call of duty. It's much more than a Monday to Friday 9 to 5 for many of you, and we really appreciate that because these are people that we really care for and are precious to us. So I've thrown a lot of information at you. I've got a PDF copy of the notes that I'll leave with Alessandra if you want to get a copy of that, and then that will include my email as well if ever you want to reach out to me. But that's what I wanted to offer and maybe start the conversation. I don't know if there's issues or concerns or things that made you upset or things that struck your fancy or.
Not at all. I think this was a very important talk, and I think we're hearing from fellow helpers of people, and the clergy. We should be partners with clergy. We should not be antagonists. So this is very, I think, a very important discussion. I mean, I have many questions and comments, but I'd like to leave it open to people. I'll jump in if needed. Is there anybody out there had questions for the Reverend Coppieters or observations from their own experience or clinical practice?
Nicholas.
Hi, Reverend Coppieters, right? Did I pronounce it
Joel
right?
is fine. Joel is fine. Joel is okay. Yeah.
Hi. Sorry. Okay. So, I just have a question. Thank you for everything that you said. I have a few questions.
Okay.
Because first of all, I did because I'm a clinical nurse, and I did one of my internships with the Open Door in Montreal.
Yeah.
Not in like my stages. So like to what extent do you guys have backlashes from the community in the sense of like and I'm not talking about like, for example, like just like the homeless people, but just in general, like because you are a religious group at the end of the day, how does the community like generally like perceive you?
There's
and sorry, and like this is like adding on to the laicite, like what we're just talking about.
Nicholas, are you talking about the medical community or the general community? How do they perceive the Reverend?
Both, because like for me, like say for example, I'm trying to make an outreach towards him. Like how will he see this from both me as a clinician and also as just also like the general community, like how they see his outreach program.
So it's interesting because when the relationship starts, there's always, particularly with a new relationship, there's always a moment of fear and hesitation. So I'll never forget the first time that the CLSC here, it's CLSC de la Montagne, I think it's called in the corner here. The first time they called me, they'd heard through the grapevine because we were at a borough council meeting together, and so one of the nurses called me and said, we've got a family and they've been here. They need food. It's an emergency, and I've got a food basket coming from them from another group, but it won't be there till Monday. They need something for the weekend. I understand that you might be able to get them food. And I said, yeah, we can do that. So as she was about to give me the name and the address of the family to bring them some food, she hesitated for a moment, and then she said, you're a pastor, aren't you? And I said, yes. She said, if I give you their name and address, you're not going to do anything weird, are you? And I said, well, what do you mean? She says, well, you're not going to show up and start preaching to them and try and convert them or anything, or try and, I said, no. I said, they need food. I'll bring them food, and it's like, and then it was interesting. I said, so I did that. And so the first couple of times when they referred somebody, they were really cautious about, who I was about. And so it takes a couple times when the relationship starts to figure out, where those lines are and how we collaborate. And the same thing with the cenotaph at the park, when the Legion asks us to do that. Okay, they want me to pray for the veterans, but it's not the moment to get into a 45-minute prayer with, speaking in tongues and all kinds of weird stuff that, so on both sides, we need to sort of figure out where that comfort space is. And for us as people of faith, we don't help the community because it gives us an excuse to proselytize or share our faith. We help the community because that's what we're called to do. We believe that as followers of Christ, we're there to help the community, and it has nothing to do necessarily with sharing our faith or with bringing more people to the service, or so there's that. Yeah, but you're right. So there's in French we say méfiance. There's that on both sides. Okay, what's your motive? Why are you here? Why are you? And sometimes it becomes good natured. I go to the borough council meeting every month just because there's a lot of issues and groups that we work with. But there's this running joke at the borough council when they see me arrive. One of the city councilors a couple times, okay, watch your language guide. The Reverend is here. Can't swear tonight. The pastor's there. So, but there's that. But you're right. It takes that feeling things on both sides in both directions.
Mm-hmm. That's a very good question, Nicholas. Any follow-up comments, Nicholas, on that?
Again, like we talked about like backlash from the community, because like sometimes like some outreach programs like this like will have like some negative other community will see this as negative, and like so like again like, and also like but I do think that you did answer my question very well, like Reverend Coppieters. Thank you.
And we understand, of course, that in Quebec there's a history and a background to this. For many years, the Roman Catholic Church had a gridlock hold on hospitals, on education, on healthcare, on all of that, and that's not always perceived in a positive light. Now we look back at that in one sense, grateful that Christian people did those things, but realizing that there was a bit of abuse of power and abuse of position. And so today we're still, I think our move towards laicite is still dealing with that a little bit. And so because there's some of those painful memories, whenever it seems like religious people are getting involved with healthcare or with educate or with community work, we're like, not sure if we want to go back there, So there's part of that collective memory that we've got as Québécois, French Canadians that makes us a little more hesitant.
Mm. I think you're right. I think you're right. I'll take the other side just for a second. The vignette you talked about where the surgeon said, "Don't thank God, thank me. I did the surgery." I'll just say I think that's not a culturally aware perspective to take. I mean, if a person says, "Thank God for what's happening," in their lives, I think that clinicians need to sort of respect those beliefs and respect that gratitude. I think one of the things that religious workers like you, Reverend Joel, I think you can help us forgive. You can help us be more grateful and more humble as well. I think those are spiritual qualities that many clinicians are working to improve. Many people are. So I just wanted to highlight that little incident. I think that's not a, I think that's clinically, I mean, sure, the surgeon did the work. That's fine. We can thank the surgeon for the good work and so on, but I think there's also some people have this other idea of a higher power and that they want to offer gratitude. And that should be encouraged as a healing modality, really. So anyway, I'm bringing this back in to sort of right the balance a little between laïcité and the religious community. So I don't know if you have any comments on that, Joel. I mean, just on those kinds of.
I've had a couple of really interesting moments in both directions, moments of challenge and moments where I always was welcome. I have one of our young immigrant women. She had two little ones, and she was pregnant for a third. Um, and we were kind of following her. We helped with diapers and preparation for the birth of the third little one. And so I had her cell phone number on my speed dial on my cell phone. And I was here in the office working late. It was past midnight. It was 12:15, 12:30, and my cell phone rang and it was her number. And so I picked up and I tracked. I knew she was about due for the delivery. And I said, "Oh, Colleen, it's great. Are you going to labor?" And then another voice said, "Actually, this is Colleen's doctor. We're in the birthing center at the Jewish General. And for 2 days, there has not been a heartbeat on the fetus. And Colleen has to deliver a stillborn little one tonight. Little one's dead, but we have to go through delivery." And she said, "You're her pastor, and she'd like you to come and pray before the delivery." And so I put my coat, or jogged across the street. It was the first time I'd been right in the birthing center, and they were ready for the delivery. And I was ushered right into the birthing center. Colleen was in the bed, and she'd had the epidural, or there was and with the doctor and the dwella and two or three nurses there, and the doctor says, "Okay, pray." But it was a really interesting setting. But I appreciated the fact that the they actually paused and they respected Colleen's request that I come and pray for her. And I thought that was really a gift from them to not to me, but really to Colleen, that in that moment of, she realized she was giving birth to this little stillborn little boy, and she realized that it was,
Tough situation.
but there are a lot of moments like that where I've seen what I think is very helpful,
Yeah,
deferential
that is.
collaboration from the medical staff to realize that this faith component for many people is an important part of their.
Hmm. That's a very good example, actually. Yeah, I appreciate you sharing that. We have to find out. I mean, I really liked you in your 12 points of what religious communities, faith communities should be able to do well. I think that's a message a lot of clinicians don't know, that a lot of clinicians need to know about, because clinicians have things that we have things we do well, right? Clinicians. We have things we don't do so well. We don't know about all those aspects you were highlighting. So I really think that's an important a gap to fill, a knowledge gap that you help to fill today with that.
One of the knowledge gaps on our end as ministers and clergy, because we're very, very busy, um, even with the basic mental health diagnosis,
Mhm.
it's very it's very hard for me to it's very hard for us to get some basic information. Like I wish a couple times I've asked a friend, I wish there was like a 30-page manual on, okay, this is what this is what depression looks like, this is what schizophrenia looks like, these are the things you might see from somebody in your congregation who's got a first episode psychosis, these are the red flags for somebody who's got early onset dementia, these are the I find that I've had to pick up all of these like a piece at a time. As I've worked with you, Dr. Jarvis, with the first episode psychosis, but I've got somebody else that I've connected to about, dementia and the first steps and Alzheimer's and picking up that way. And then I've got a couple people, I've got 3, I think, in the congregation who are bipolar. And so the process of helping them has, as I helped the 2 or 3 of them, I thought, oh, I think this is Bob's problem, but he's not diagnosed, and I go, whoa, Bob's doing this, and it's like, so I've often wished that there was some literature or some resources or something that I don't know if there is that. I don't know if there's a short manual somewhere that I could recommend to my colleagues. Mm-hmm. Nicholas, did you have a?
Hi, sorry. So I was just gonna mention this because the PEP again, like the PEP is the clinic. The clinics are very individualized according to your postal code. They're very mean, depending on your postal code, like where you live. Like we'll cover you, or we'll just move you to like another group. But at the same time, at the PEP Montreal, we are doing this thing where like it's a recent thing where we're trying to like do more like outreach, so like go out to the community just to explain what services are offered. So like I'll give you an example, Reverend Joel. So for example, if you have somebody in your congregation, like a family, and you have like a young person between, like, for us it's like 14 to 35, that you have some worries or whatever. For us, you can make a referral to us directly to us, and someone usually like that's the way that the PEP system works, is that someone's gonna contact the person in like 72 hours minimum. So even if you're not from like our sector, we will be able to like reach out or like send a recommendation to someone else. My other question for you, like Reverend Joel, was like because you said like, this is something that I find very interesting and that might help us, that you're capable of actually doing an outreach without invitation. Like, say for example, because of the fact that you are a minister, that you can like just go knock on someone's door and be like, hey, I am here, I just want to check up on you. So like now my question was like, would you be allowed to be accompanied by somebody?
Yeah, often I bring someone with me. I try never to do those visits alone for a couple of reasons. I mean, there's been enough horror stories like this that if I know there's a woman alone, if I know there's a young woman alone, I just want to avoid the appearance of scandal. I want to and then somebody senior, an older person, I want to keep things clear. And also for educate, I've got a team of elders. They're people from the congregation who are a little more experienced, and I often bring them along with me, just to gives them a chance to make that connection. But yeah, I do that. Yeah, I do occasionally bring someone with me, and I typically there's two things that are the entrance for me. The fact that we run a little food bank is really, really helpful. We in the field of work in the community, we say that food is more than just food. And sometimes we've got families who have huge mental health issues. They've got huge social issues they're dealing with. They've got a bunch of other issues, legal issues, immigration, but all of those things, you can kind of sweep them under the carpet. But if you haven't eaten for 2 days, you need to eat. And so often families who have struggles, it ends up materializing financially with a shortage of food, shortage of money, and you get to the point you can only go for so many days without eating. And so often for me, it's stopping by with a food basket or a couple of groceries, that gets me in the door. If I called them and I said, look, I think you've got a mental health issue and you've got dementia, I'd like to talk to you about going to the clinic with me, they wouldn't have me. But if
Yeah,
I call and
I
say,
agree
look,
with.
I get the feeling you could use a few groceries. We bought a load of meat and fresh fruits and vegetables for the congregation. I was going to stop by. Would be okay if I, so often for me, it's can I stop by and have a word of prayer with you? Can I stop by and bring you a couple groceries? And that's the door in, and that gets me in the front door. That gets me seated at the kitchen table, and from the kitchen table, there's stuff you see. You look in the bedroom and you realize the mom is sleeping on a mattress on the ground with her two kids, and there's no beds and there's no cribs, and you realize something else is going on. You're there, and you're, yeah.
Mm-hmm.
But yeah, there's that. Um, there's moments where I do that, and I've gotten fairly well connected with the local police as well. Um, the police know that if they show up at the door, it's already escalated things. If there's a 911 call and it's two police officers in uniform with a gun at their side with a walkie-talkie that show up at the door, already that's taken stuff up a notch. There's a couple times with a few of the police locally, because they know me, they think, we're worried about this guy. Could you just stop by and check sometime? And a few times I've stopped by, I've checked, and I've said, I called 911. I said, yeah, you need to come. And other times I said, no, it's we're okay. He just needs to go to the CLSC. And um,
I wonder if, Nicholas, were you asking whether a clinician could tag team with someone like Joel for certain people to reach out to them?
Uh,
Is that what
yes,
you were?
exactly. Yes, exactly. Because like sometimes like we've tried to do an outreach towards a client. We'll go knock on the door, like the client doesn't open the door. But then like, so like my question was like exactly like what you said, like if we could like go together, if that could like again like open the door a little bit more.
and particularly in contexts where there's a faith piece there, um, it's
Exactly. Because like for me, it's usually like if I have a client who does have like who is more open to like clergy, but then they'll be like, so long as you come with clergy with me, like I'm fine with that. Like,
Yeah, exactly. No, I think that's really important. I think there's a couple of things to note. One is a study that I read years ago from Norway. They compared the kinds of people family doctors see and the kinds of people that clergy see, and the level of distress was about the same. So clergy see a lot of people with fairly significant distress, mental health distress, I mean. Just to keep that in mind, they have quite a bit of experience. And the second thing is that religious communities are quite quite deeply embedded networks. So mental health practitioners generally ignore those networks, but our patients don't. So I think it's like Nicholas, what you're saying is I think very important. That we can, if we're wise clinicians, I think we can open our minds, open our hearts to the people working around us in faith communities, and often they can be very helpful. They can help us. You've heard Joel talking about bringing food, bringing comfort, bringing basic necessities to a lot of people in the community. So this is anyway. So I think it goes back to your question. I hope we can tag team more often. Find ways to do that.
and there is, by the way, an open, particularly those of you who are nearby at the Jewish General here. I mean, as you do your clinical work, I'm sure there's moments where you realize that you're struggling helping with someone who, on top of the mental health issues they're dealing with, that they're probably not eating enough, or that there's, if there's moments like that where we can help you make that connection. Because I realize that the Jewish General's calling does not include bringing a food basket to somebody's home who's, so as you work with somebody, if you see somebody where, needs um,
We do have food baskets once a year at least. Like around the Christmas season, there's some donors give money sometimes. So there are some things like that, but it's not the same. It's not on an ongoing, constant basis. I think many of the religious communities are much more consistent on that than the medical communities are.
so I want to tell you one more story. Um, as a congregation, we've really made a decision to be caring and welcoming, including with mental health issues, with people struggling with that. And that creates little things in the congregation that people have, that were hard for people at first a little bit, because there's those societal norms of behavior that we all understand that are, that sometimes get stretched a little bit when we, and Alessandra and Eric, you've probably heard the story, but it was my first Easter at Côte-des-Neiges, and Easter Sunday is a big service for Christians. There's a lot of Christians that never come during the rest of the year, but they show up on Easter Sunday. So that's the and so the place is full, and it's always a nice service, and the choir does more pieces, and we bring a couple more musicians in. It's always a nice, beautiful service, and there's fresh flowers out and candles are out. It's a big, it's a big celebration, big moment here for us. And I had a lady in the congregation. Her name was Sonia. Kind of hard story. Her domestic violence. Her husband beat her so badly that it inflicted brain damage. And so she was divorced. She had left him, and her kids were sort of distant from her because she'd become so dangerous because of the, between the medication, because of the brain damage, but she was regularly coming to services. And so on Easter Sunday, so we go through the service, and at the end of our Presbyterian service, we sing a last hymn, and everybody's standing, and the musicians are still sort of, and I end with a benediction, and I put my hands up, and there's a little prayer that I say with the congregation. And Sonia hops up, and she starts running for me, and she starts yelling, "I gotta talk to you, I gotta," and I can hear everybody in the congregation just go, "Oh, not today. Like, it was such a nice service, and my kids are here, and my grandmother's here, did she have to just create a scene today?" It was like, and I had this split-second moment to make a decision. Okay, am I going to, I confess that the gut that came to my mind was, okay, Sonia, sit down, be quiet. The service is almost over. I'll talk to you, and it's like, but she came running right for me. And I thought, okay, Sonia, I just got to finish this, okay, and then we can talk. And so she came up, and and I wound up with one arm around her, and I put my right hand up to do the benediction, and Sonia and she put her hand up. So Sonia and I kind of did the benediction together. And then after we went down for coffee time, we had tea together, and she had not been able to renew a prescription, needed a bit of help, and so we arranged that for her. And about a year and a half later, I had a couple who called to see me, and they were struggling in their relationship. They wanted to chat, so they came in my office, and we had tea and cookies together over a couple of evenings just to chat and work out some of the stress. And after about 2 or 3 evenings, as they were leaving, the husband, and professional couple, he's an engineer, she's a notary, they're stable people, well-to-do, and as they were leaving, the husband turns to me and he says, "Pastor," says, "you know why we come to this church?" And my gut reaction, well, there's a good pastor, you like my preaching, like, I don't know, I thought, and I said, well, why do you come? And he said, "You remember Easter Sunday last year?" He says, "You remember that lady who came running to the front, He said, the whole congregation was waiting for you to yell at her, to just sit down and be quiet, and we were all disappointed, it's like," and he said, "Then you just put your arm around her, and she did the benediction with you, And he said, when I saw that, I thought to myself, if she's okay here, I'm okay here."
Oh, that's nice.
And so it's been interesting as a community of faith, as we've wrestled together to take care of people who are on the edge, who are on the periphery in terms of mental. It takes effort, and it takes courage. Sometimes it's frustrating, and it means that we have to watch, and not. But it also means that for the rest of the congregation, it really sets this tone in the congregation that says that this is who we are. We take care of people, and if you're struggling, you're okay here. We're and I think as a society, as we who was it that said that you can judge a society by the way it takes care of the most vulnerable in the society. Anyway, so I think that with the mental health issues that you're wrestling with, and people you're taking care of, I think that's part of the message that we send to the rest of the community around us, that we take care of each other.
I think it's a great way to end the seminar, and I think it's a great example to our clinical settings to also be inclusive, to help people to belong to our clinics, and make people feel more welcome. I think we can learn a lot from our communities of faith who are working with us. So I think I'm just, oh, here, there's somebody, we can probably end there. We have more meetings with Reverend Joel, but we have more seminars coming, so we'll certainly invite Reverend Joel back if he's willing.
Yep.
Come give us a part two. I think it's a message that needs to be heard
Yeah.
by a wider
And I'm
variety.
always sort of part of the team too, so I'm in the background there with the.
That is a point that I wanted to raise. Thank you so much, Joel. You mentioned several, so many points that are worth investigating further. Just one that could be something to see in the future. You mentioned that you have many international students. We do have many international students from Africa, for instance, who are hard time adjusting. Sometimes they start to use drugs and they find themselves in a very difficult space and time. So something nice for you as well to tell us what you're doing with this group of people.
That'd be great.
Thank you for the opportunity. I really appreciate
Thank you.
this. Yeah.
Thank you for coming, Reverend Coppieters, and everyone, for your questions, comments too. This is very important. So we'll continue. We'll look for other opportunities.